A detailed understanding of the venous system of the upper and lower extremities will facilitate successful cannulation. The upper extremities have two primary venous systems: the cephalic vein, traveling on the radial side of the forearm, and the basilic vein, originating from the ulnar side of the forearm. Although venous anatomy may vary considerably from patient to patient, these two systems generally remain distinct, other than communicating at the antecubital fossa and the wrist. However, be careful to avoid inadvertently cannulating the brachial artery, which usually lies just medial to the median cubital vein. The same applies for the radial and ulnar arteries at the level of the wrist. Use careful palpation to identify arterial pulsations to minimize the possibility of this complication. The venous system of the lower extremities consists of the greater and lesser saphenous veins, cannulated in acute situations, as it accommodates large bore catheters and may be easier to cannulate. When upper extremity veins are inaccessible, the dorsal veins of the foot or the saphenous veins of the lower extremity may be used. Cannulation of lower extremity veins is associated with a higher incidence of thrombosis and embolism as compared with upper extremity veins. This risk is lower in children and infants. Therefore, the veins of the legs and feet are an acceptable alternative when cannulation of the upper extremities has failed. Other alternative intravenous cannulation sites include scalp veins, used in neonates and young infants, and the external jugular vein. Peripheral intravenous catheterization is required in a broad range of clinical applications, including intravenous drug administration, for intravenous hydration, transfusions of blood or blood components, during surgery, during emergency care, and in other situations in which direct access to the bloodstream is needed. When a vein is difficult to see or to identify on palpation, several methods can be used to increase its dilatation. These include lowering the arm below heart level, gently tapping on the vein, instructing the patient to open and close his or her fist repeatedly, and applying a warm compress to the selected site for 3 to 5 minutes to increase vasodilatation. Transillumination or ultrasound may also be used to help locate a vein. These have been shown to improve the success rate of the procedure and to reduce the amount of time needed to perform it. Blood might flash back into the chamber if the tip of the needle has entered the lumen, but the cannula has not yet entered the vessel lumen itself. This problem can be avoided by reducing the angle of the catheter and advancing the needle a few more millimeters into the vein. A valve within the vein may prevent advancement of an inserted catheter. If this occurs, hold the cannula hub in place, remove the tourniquet, and connect the intravenous tubing to the cannula. Running fluid into the vein may open the valve and allow the cannula to be completely inserted. Occasionally, it is possible to advance the catheter when it is outside the vein or when the catheter has perforated the vein's opposite wall. Either of these situations can cause pain and swelling at the insertion site because the intravenous fluids are administered into subcutaneous tissue, When this occurs, the cannula should be withdrawn completely, and another cannula should be placed at an alternative site. When a cannulation attempt is unsuccessful, the subsequent attempt should be performed in a vein proximal to the initial puncture site. The most common complications arising from intravenous cannulation are pain, bruising, bacterial infection, extravasation, possibly leading to necrosis, phlebitis, thrombosis, embolism, and nerve damage. Proper sterile technique and the selection of an appropriately sized catheter should help to avoid these complications. Ensure proper and adequate fluid administration or flush the site with saline to prevent the more serious complications of thrombosis and embolism. An attempt should also be made to prevent IV fluid bags from becoming empty, which may cause cannula obstruction from blood clots or the infusion of air. If fluid extravasation or thrombosis occurs, remove the cannula immediately and place a new line if needed. The chances of successful peripheral intravenous cannulation increase with meticulous attention to proper technique, the use of proper equipment, familiarity with anatomy, and a knowledge of a variety of approaches to accessing peripheral veins. Relative contraindications to inserting a peripheral catheter in a specific site may include infection, phlebitis, sclerosed veins, previous intravenous infiltration, burns or traumatic injury proximal to the insertion site, arteriovenous fistula in an extremity, and surgical procedures affecting an extremity. Other situations may preclude obtaining peripheral intravenous access. For instance, extreme dehydration or shock may render cannulating collapsed peripheral veins impossible. Some patients may lack suitable peripheral veins because of prior chemotherapy or intravenous substance abuse. When access to peripheral veins is impossible, and in other situations in which accessing peripheral veins may take too long, insertion of a central venous or intraosseous catheter or peripheral venous cut-down may be required.